We got a pretty full agenda, so we're going to jump right in. Today, our subject is on the response element of the hemorrhage bundle, and we're going to be looking at OB hemorrhage emergency management. Today, our speaker is Jennifer Boland. Jennifer is currently in the position as the maternal outreach educator for the Macon perinatal region. She is an experienced nurse. She's been a nurse now for 17 years. In labor and delivery, her specialty is high-risk obstetrics. Jennifer has had quite an extensive background. She's ACLS OB instructor, BLS and NRP instructor, also an instructor for A1 fetal monitoring, intermediate and advanced. She's got experience as a charge nurse, OR and PACU experience, and she has a master's degree in nursing. And Jennifer has spent most of her time at Medical Center in Navicent. So we're really pleased for Jennifer to share her knowledge and experience with us. And I'm going to hand it over to you, Jennifer. Thank you so much.
Thank you, Lauren. Good afternoon, everyone. Thank you for joining us today as we are going to discuss response as it pertains to the OB emergency management. Okay, Grace. Next. All right, so we've covered a number of topics in the AIM Safety Bundle for OB hemorrhage in our monthly webinars. So far, we've shared information on 2 out of the 4 pillars. The first pillar, readiness, which related to how will every unit be ready to handle an OB hemorrhage. And then the second pillar, recognition and prevention, was related to how will the unit treat every patient coming in to the unit for childbirth. Next. Today, we're going to discuss the third pillar, response. Response pillar recommends best practices on how your facility should handle all OB hemorrhages. The first recommendation is that every hemorrhage should be treated using a unit standard stage-based obstetric hemorrhage emergency management plan with checklists. On September 21st of 2017, ACOG did release an expanded guidance on postpartum hemorrhage to include recommendations for standard hospital-wide protocols and potential treatments. The second recommendation is that your facility have programs for patients, families, and staff for all significant hemorrhages. These resources may include your employee assistance programs for your employees, chaplains, social workers, counselors, or any other community resources. The key is just to ensure that the appropriate referrals are made for our patients, our families, and our employees to help them cope with the trauma that can be associated with significant unexpected outcomes. Next. Hemorrhage is defined as cumulative blood loss that is greater than or equal to 1,000 mLs or a blood loss that is accompanied by signs and symptoms of hypovolemia. However, a blood loss of greater than 500 mLs in a vaginal delivery warrants prompt investigation. Just due to normal physiological changes in pregnancy, including the increased circulating volume, tachycardia and hypotension are going to be late signs of blood loss in our moms. Hemorrhages are classified as either primary or secondary. Primary hemorrhages are those hemorrhages that are going to occur within the first 24 hours of delivery, while secondary hemorrhages occur anytime from 24 hours post-delivery up to 12 weeks postpartum. Next. So what causes an OB hemorrhage? Let's look at some of the primary etiologies for OB hemorrhage. One way we can remember some of these is to think about the 4 T's, tone, trauma, tissue, and thrombin. So first we'll talk about tone. This refers to any abnormal uterine tone. We know that uterine atony causes 70 to 80% of postpartum hemorrhages and should be considered first as a primary cause of an OB hemorrhage. Next is trauma. Trauma is going to refer to any damage to the tissue or muscles, such as any lacerations, episiotomies, uterine rupture, or uterine inversion. The third is tissue. This refers to tissue that may be left behind, such as a retained placenta or abnormal implantation of your placenta, such as placenta accreta, increta, or percreta. And last is thrombin. And this refers to abnormalities with coagulation as a result of preeclampsia, if the patient has any inherited clotting deficiencies, any infections, an amniotic fluid embolus, and sometimes even our therapeutic anticoagulation can cause defects. Next. So if faced with an OB hemorrhage, how should we manage it? First, treatment should be based on the etiology of the hemorrhage. So we can ask ourselves, why is our patient hemorrhaging? Again, this is a good time to remember the 4 T's we just discussed about our tone, trauma, tissue, and thrombin. One goal of management is going to be to maintain hemodynamic stability while we identify and treat the underlying cause. Management of the postpartum hemorrhage should use a multidisciplinary and stepwise approach that is standardized and provides actions and treatments to help maintain that hemodynamic stability and hopefully alleviate the underlying cause. Utilizing such standardized multi-stage approach in response to hemorrhages has been associated with earlier intervention as well as being able to resolve the hemorrhage at an earlier stage. Again, the algorithms and checklists for postpartum hemorrhage have been created and are aimed at treating hemorrhage early and consistently, as well as being able to identify the need for more aggressive interventions. These algorithms should be completed, again, in that stepwise fashion that are stage-based. So as your escalation to more aggressive interventions occur, so should escalation of intensity of care and support personnel should be reflected in those algorithms. So I've listed some resources here on the slide that are available to help you and your facility kind of come up with your own algorithms that will fit your facilities. Next. So what about our smaller, more rural hospitals? They are not going to have the resources that the larger regional centers or inner city hospitals may have. So that's why these facilities with limited resources need a good comprehensive plan in place for OB emergencies, including hemorrhage. So that plan needs to include an assessment of resources that may or may not be available. Those resources may be within the facility itself, or they may need to look at nearby surrounding areas for possible resources. The plan should also consider transferring at-risk patients to a higher level of care before an emergency arises. Next. So let's take a few minutes and we're going to talk about the different stages of a hemorrhage. The California Maternal Quality Care Collaborative Toolkit for OB Hemorrhage is an excellent resource to assist you and your facility in developing algorithms and checklists along with your protocol. ACOG and AWAN, they also have resources available so that you can devise the best plan for your facility. So stage 0 is really for all births. And the interventions that are listed are really there to not only prevent hemorrhages, but to also recognize a hemorrhage when one occurs. So you can see in the yellow box on the slide that there is a list of indications of a hemorrhage and the necessity to move up the ladder and proceed to stage 1. Next. So here you can see the criteria listed for stage 1 hemorrhage. Next. If you note the interventions on the left side are listed in blue, these are going to be the interventions of our primary nurse. The physician's interventions are listed on the right side in green. These interventions also serve as a checklist so that the nurse and the physician can collaborate with one another. They can kind of see what's been done, what has not been done. And this will allow them to kind of move in progression together. And the interventions and the checklist, they also serve kind of like a checks and balances and helps the team to not forget or possibly skip a vital step. Now, if these interventions do not alleviate the hemorrhage or we still have continued bleeding, next, Grace, then you can see the listed criteria in the yellow box that would then proceed to stage 2. Next. So before we go on to stage 2, I wanted just to include a table that does list the drugs that are most commonly used in treatment for uterine atony. You can see listed, we have the actual drug, the correct dose, the correct route, dose frequency, side effects, contraindication, and storage requirements for each medication. Okay, next. So we'll move up the ladder to our stage 2 hemorrhage. So as the severity of the hemorrhage increases, so should the patient care, should also intensify, and we should have available additional resources. Next. As you can see, we still have our primary nurses task listed in blue. The physicians are going to be listed in green, and then the purple will also have our charge nurses' roles and interventions listed. So you can see that with the purple, you've got that secondary nurse or the charge nurse, and they're going to be given specific tasks that will assist the team so that they are not pulled away from taking care of the patient. So in the middle is their blue column, and again, we've still got our primary nurses taking care of the patient. So with that additional help, she's able to focus and be able to communicate with our physician. So on the last is our physicians. So also note, next, Grace, at the bottom we have, one more time, we also have blood bank coming involved now, and blood bank is going to play a reported role. We also have our charge nurse or our secondary nurse has notified our response team. So now we have incorporated our multidisciplinary team that's also going to be able to focus on our patient. Next. So now we'll just kind of look at some of the tone, trauma, tissue, and thrombin, again, as it relates to stage 2. Next. And so these are some of the interventions that may be expected to be done by the physician. So for vaginal delivery, for tone, we want to improve our uterine atony, but we may use an intrauterine balloon if our uterotonic drugs and our uterine massage were not effective. Trauma may be related to high vaginal or cervical lacerations that may need repair. And then tissues such as retained placenta may require the need for a DNC. For our C-section, compression sutures may be utilized for uterine atony, repair of a uterine rupture if the repair is possible. If not, it may result in a hysterectomy. May have abnormal implantation, again, of the placenta, and depending on that severity, the tissue may be able to be removed, but if not, a hysterectomy would be performed. And next, other etiologies, next. Other etiologies that may be related to uterine inversion are uterine inversion and amniotic embolism. So again, you can see that as the severity of our mom's outcome increases or the need for further interventions or more aggressive interventions, we're going to need additional support from anesthesia and blood bank. Next. Next. So here is our yellow box again, and this is going to list our criteria. We're going to continue to reevaluate our bleeding and our mom's vital signs. And if our cumulative blood loss is now greater than 1,500 mLs, we've given greater than 2 units of packed red blood cells, or our mom's vital signs are unstable, or we have a suspicion for DIC, then we're going to progress up our ladder and we're going to proceed to stage 3. Next. So stage 3 is a serious situation and therefore calls for additional support beyond what is already present. So again, the different colors represent different groups of people and their roles. As the situation intensifies, so does the care of the patient, and our algorithm should reflect that by allowing identification of additional support personnel. On this slide, our dark blue over on the left is still our primary nurse. However, we've added 2 additional nurses to our charge nurse role in purple. The green represents our OB physician and their interventions, but we've also added anesthesia, who will be assisting with arterial blood gases, placing A-lines, any central lines, offering any vasopressor support, or even intubation if we need that. The light blue on the right represents options for our physician to consider, such as etiology based on the interventions that have maybe not yet been completed, other things to prevent hypothermia and acidemia, and then to look at conservative or definitive surgery if that is needed, and to move the patient to the OR if they are not already there. Again, at the bottom, you note that the blood bank is still playing an important role, and we would be hopefully staying ahead of our blood products that are being issued and our blood products that are being needed. Next. So these are some blood products that can be given anytime during any stage of a hemorrhage. So this slide just shows the products that are used and lists their indications. So for our packed red blood cells, this is going to be our best first-line product for blood loss, and we can transfuse the O-negative blood in emergencies. Your fresh frozen plasma, this typically is going to be given if more than 2 units of packed red blood cells is given, or if you've got a prolonged PT. Your platelets should be given priority if your platelets are less than 50,000. And then your cryoprecipitate if your priority is if your fibrinogen is less than 80. And this is best for DIC with the low fibrinogen and no need for volume replacement. Next. So I know that on the previous slides with all the stages, there's a lot of information packed into the algorithms and the checklist. So I just wanted to pull out some of the medical and surgical approaches to an OB hemorrhage management. So some of the medical management will include the use of those uterotonic agents that were listed in the previous table, bimanual uterine exam and massage, uterine tamponade techniques, which include the use of the intrauterine balloon, which is pictured here, the use of a Foley catheter, or the use of uterine packing, and then another medical management would also be for uterine artery embolization. Next. So some surgical management approach would include a DNC, vascular ligation, uterine compression sutures such as the B-Lynch suture technique, which is pictured, and then also a hysterectomy. Next. So unexpected events such as undiagnosed placenta accretas, uterine ruptures, and an inverted uterus can occur. These are emergencies in themselves, and each of these can lead to a hemorrhage emergency as well. So both some of the medical and surgical approaches that we've already discussed are used to correct these issues, and early identification of these issues may also prevent an OB hemorrhage emergency. Identification of a secondary hemorrhage early is also helpful in preventing the progression of a hemorrhage. Next. So here is some more resources that are used and some helpful links. I do appreciate your participation, and I hope that I've helped cover what is needed to appropriately manage an OB emergency for hemorrhage. Thank you.